Hi guys. Can you hear me?
Yes.
Okay. So welcome to today's CME. My name is Lena. I'm going to be your moderator today. An incoming fourth year at UON doing medicine, and I'm very excited for today. Hope we have a good time, a very interactive and informative hour. Yes. So today we're going to be led by Felix, a very able founder, and the topic is valvular heart diseases. So we'll have the talk, and then we'll have a Kahoot session, a Q&A session, and then we'll have an announcement from Hadia. So I hope you all have a good time, and yeah, let me invite Felix to introduce himself and get started. Yeah.
Thanks for the introduction, Lena. I hope I'm also audible.
Yes, you are.
Let me try to share my screen. Figure this out. So I'm sharing from my tablet. So just kindly confirm if you can see my screen.
Yes, you can see your screen.
Okay, nice. So we'll just get started. So the topic of today is valvular heart disease, and it's an important topic. It's one of the most common conditions of the heart, and it's important in terms of because the epidemiology and also the pathology and also just generally also for exam purposes. And so what we'll be going through, we'll be looking at the different types of valvular heart diseases, how they present clinically, their etiology, pathophysiology, and just in a pretty simple way because it's a really wide topic. So trying to summarize it, as well as rheumatic fever, infective endocarditis, non-infective endocarditis, and just a small slide on prosthetic valves. So to get started, so we look at the anatomy as well as the physiology, so that we're able to lay a nice foundation or a nice background for being able to understand what heart valves are, why they're important, and basically what goes wrong and how it goes wrong and how it presents. So in the heart, we usually have two sets of valves. Yeah, so excuse my bad handwriting. So you have semilunar valves and you have atrioventricular valves. So the semilunar valves are these aortic and pulmonary valves that you can see here that usually regulates that entry into the major outlets from the ventricles of the heart, which are, for the pulmonary, it's pulmonary artery, it's the right ventricle. For the aorta, it's the left ventricle. And you can see how they look. They usually have this Mercedes-Benz logo appearance, as you can see there. And then the atrioventricular valves, you have bicuspid on the left and tricuspid on the right. Bicuspid is also known as the mitral valve, which you can see over here. And basically, the function of valves is to prevent backflow of blood, particularly in a closed circulation like the ones that humans and mammals have. It's important so that blood moves in one direction so that you're able to supply the body with blood and other various organs in the circulation with nutrients without overloading the heart. So we look at what these valves usually look like normally. So just doing a short review of the anatomy, because this is going to be more of a combination of pathology and bit of IMED. So this is what normal semilunar valves would look like. So this is the root of the aorta up here, which has been opened up. And you can see you usually have three cusps, and these cusps form cups. So they look like, semilunar means half moon. So they look like cups that form what is known as, this is a aorta. So they are what is known as aortic sinuses. And these aortic sinuses usually serve as a pool or a collection of blood during relaxation, during diastole, such that they fill up. And it's from these sinuses that the coronary circulation emerges from. And you usually have the right coronary artery coming from the anterior aortic sinus, the left coronary artery coming from the left posterior sinus, and then you usually have an uncoronary sinus, which is the right posterior sinus, and then you have the same kind of similar thing in the right, on the right, where you have the pulmonary artery, just that the names usually interchange. So what is important to just appreciate here is how smooth this is. Normal, this is how smooth it looks. And an important thing is what provides integrity of this set of valves. And whatever is responsible for this integrity is, number one, the cusps themselves. So these cusps should be able to open and close. So that, because valves serve like gates, they work like gates, and gates, it should open when you want to pass, and it should close after you've passed, so it doesn't let whatever has gone come back. So cusps are the primary integrity, and then you also have cuspal attachments, which are the attachment to the wall of this vessel. So you'll find that in some cases the wall may be compromised, and that will also therefore affect the cusps themselves. So think of hinges, like the hinges of a gate, those hinges that attach the gate to the whatever the frame. So if those ones are affected, you'll also have a compromised integrity of that valve. So we look at what the normal atrioventricular valve looks like. So here we have the tricuspid valve. You can see it has three. 1, 2, 3. So these are the leaflets. You usually have, I think, anterior, posterior, and septal. And you have coinciding, corresponding papillary muscles coming from the ventricle. And for these ones, their integrity is dependent on the leaflets themselves. So again, they should be able to open and close when needed. Their attachment on the wall. So again, the attachment is very, very important, such that whenever the wall is compromised or it's stretched too much, the integrity of that valve is also going to be compromised. And then you have the chordae tendinae, which are these string-like structures that you can see, and papillary muscles. So whenever any of these subvalvular apparatus is also affected, the integrity of this valve is also compromised. So that is the gross anatomy. Then looking at the histology of a valve, this is what it looks like. It usually has three important layers with endothelium on either side. So you have the fibrosa. The fibrosa is primarily made up of collagen, which provides tensile strength. And then you have the spongiosa, spongy, osa, can feel, spongy. So it has it's like a sponge. So it has like squishy substance. And this squishy substance is this glycosaminoglycans, and therefore the role is shock absorption. And then you have the ventricularis, which is mostly made up of elastin. So it's what allows it to stretch. So on a structural level, you can see the valve also has that important composition. And in some other conditions, this composition may also be affected. So you may have abnormal materials within this composition of these layers, such that the valve is no longer able to function properly. So that's for the anatomy. And then quickly going through the physiology. So the physiology is simply review the cardiac cycle. And the cardiac cycle is made up of two main phases, which is systole and diastole. Systole is a phase of contraction. Diastole is relaxation, simply put. So you know how blood moves through the heart. So remember, let's start with the oxygenated blood coming from the rest of the body, either through the SV superior vena cava or the inferior vena cava. It's going to enter the right atrium down through the tricuspid valve into the right ventricle, then pumped out through the pulmonary artery into the lungs, becomes oxygenated, comes back through the pulmonary veins into the left atrium, then again through the mitral valve into the left ventricle through the aorta into systemic circulation. So we can start looking at this. These curves are usually very, very important. The ones on your right, they help to understand and make sense of what happens in the heart. And we'll just review this really quickly. So just that's what it's fully visible. So right before you have, so during contraction, which you say is systole, what usually happens is that it's preceded by closing of the atrioventricular valves, which are the mitral valve on the right and on the left and the tricuspid on the right. So they close such that you can start contracting, and so you have a phase. The first phase of systole is what is known as isovolumetric contraction, which is this phase where both the semilunar valves, that is the aortic and pulmonary, as well as the atrioventricular valves are all closed. So you have contraction such that you're building up pressure within the ventricles, getting ready to pump blood. And so for you to start that phase, before you start that phase, you usually have closure of the atrioventricular valves, which is what gives you the first heart sound, which is known as S1, or what we call lab. And so during this phase, pressure, what is indicated in this blue line over here, will build up. And then once it reaches a critical point, which is like 80 millimeters of mercury, it's going to force the semilunar valves open. And then you will have a phase of ejection of blood. Yeah. And then once those aortic valves have opened, they'll then close. And once they close, that is what marks the start of diastole. And that closure of the semilunar valves is what gives you the F2 heart sound, or the dub. And after that, you will then have diastole, which starts with isovolumetric relaxation, such that you have relaxation of the ventricles, such that they create this negative pressure, such that blood can come. And at this phase, still the valves, all valves are closed. They only open after the end of the isovolumetric relaxation. And once the atrioventricular valves open, the blood that is in the atrial will then rush in through this rapid inflow phase. They'll then rush in to the ventricles. And that rush is what also, as that blood strikes the ventricles, that is what normally gives the third heart sound, which is not always heard, but may be heard sometimes. So it's not really pathological, but it may be pathological sometimes. And then you have a phase known as diastasis, which is just this phase between the rapid inflow and the contraction of the atria, which is known as systole, atrial systole, where the atria contracts and pushes the remaining blood into the ventricles. And then after that, the atrioventricular valves then close again, such that you go back again into the phases of systole as we've gone through. So that is important to remember. And then you can always just look at this at your own time, looking, because it also has the ECG plot, looking at what the P wave is, the QRS, because they all just coincide with each other. So in order to be able to diagnose disorders of heart valves, you need to at least have an idea of the areas where you should listen to them. These are the auscultation areas. And you usually have these 5 main ones, whereby you have the aortic valve, the aortic area, which is found at the right second intercostal space. So it's just this parasternal area, but on the right. And it's the best place for you to listen to the aortic valves and aortic valve pathologies. And then you have the pulmonic area, which is on the still on the second intercostal space, but then on the left. And then you have tricuspid area, which is on the left lower sternal border of the fourth intercostal space. And then you have the mitral area, which is in the left fifth intercostal space mid-clavicular line. So yeah. And then you have Ab's point, which is this point found at the left third intercostal space, which is this space that makes it possible to hear most of the valves. You can hear, actually, this auscultation, so that's why it's usually commonly auscultated. You can hear the aortic valve, mitral, you can hear S1, S2 clearly. So it's a place that allows you to hear all areas of these valves. So Ab's point is important to remember, and you can use the mnemonic All People Enjoy Time magazine to remember that. So now that we've laid the basics down, let's now get into the meat of the discussion for today, which is valvular heart diseases. And you can have 2 categories. You can have stenosis, and you can have insufficiency, or what is known as regurgitation. And as I mentioned, we're going to use an analogy of a gate. So stenosis is where the gate is not opening. So the blood is going to have to force its way, or it's going to struggle to pass through a narrowed opening. That is the valve. The opening is a valve. And then insufficiency is where it's not closing properly. So after blood is pumped out, what do you have? Backflow into whichever chamber it was coming from. So let's start with the first one. So again, I thought I'd have time to make the slides beautiful, but I had a busy week. But so we'll just use this. So we'll just follow. So let's start with aortic stenosis. Stenosis is narrowing. So this is the aortic valve over here. So what usually happens is that once this valve is narrowed, we look at the etiology, how various causes of aortic stenosis. What happens is that now, remember, we said that phase of during systole, that phase of isovolumetric contraction, you train to build up pressure, building up pressure by the contraction coming from the left ventricle in order to be able to push blood out, in order to be able to open the aortic valve and pump blood out. So you have a situation where that valve is not opening as normal, because it's too narrow. So what happens is that you need to have a lot of buildup of pressure from the left ventricle in order to be able to push blood out. And so this murmur that you're going to have here, because again, remember, this is during systole, the ejection phase, where you have also the contraction. It's going to, this murmur, if at all you forget everything, just remember it's a systolic murmur. Why is it systolic? Because it's manifesting during systole. That's where it's bringing the problem, because the blood is trying to be pumped out, but then the valve is too narrow. And so it's normally going to have it's an ejection murmur, a click, because you have buildup of pressure until it gets to a critical point where it finally opens, and then it just clicks, opens, and then finally it's going to go, and then it also radiates to the carotid. So that's the kind of murmur you have with aortic stenosis. And clinically, how it's going to present, you're going to have a triad of angina, syncope, and dyspnea. Angina, which is chest pain. Remember, we said the only way the heart supplies itself is through the coronary arteries. And these coronary arteries are usually situated above the root of the aorta. So if you're having issues getting blood through the aortic valve, you'll have inadequate supply of blood through the coronary arteries to supply the heart. So you'll have angina and syncope. Yeah, and so this tends to manifest mostly during exertion when you need to pump blood more. And so you have that because the demands of the body cannot be met. So people may faint as well as dyspnea. And a common manifestation is that you'll have left ventricular hypertrophy. Left ventricular hypertrophy because of pressure overload on the left ventricle, and that may ultimately lead to left ventricular, heart failure. So the causes are things like commonly rheumatic heart disease. You may have calcific valvular degeneration. That's mostly in the Western world, but in our setting, rheumatic heart disease is the most common cause. And in another cause may be what is known as bicuspid aortic valve, which is a congenital condition where the semilunar valves have a Mercedes-Benz appearance. So you may have a situation where two cusps are fused. So you have a raphe in between, they're not separated. So the space of the valve is smaller. And so it predisposes it, to also undergoing early calcific degeneration. And this is what it looks like. So this is calcific aortic stenosis, where you have calcium deposits within the valves, making them so you have an issue opening them because they've become a bit too rigid. Then this is on your right. This label B is bicuspid valve. This is bicuspid valve which is fused, congenitally fused bicuspid valve. So it's also quite narrow. And then you have rheumatic aortic stenosis, where you have fusion of the commissures, which are these corners of this valve. So in terms of auscultation, you said, you auscultate what we showed, the aortic area and Ab's point. And the murmur, if you forget everything, at least remember it's a systolic murmur. And so it's described as a crescendo, decrescendo murmur. So increases and decreases. And then the murmur characteristics, as we described, you'll have an ejection click, and it's going to radiate to the carotids. And this presentation, the triad of dyspnea, angina, and syncope. And complications, left ventricular heart failure, which may, due to pressure overload. And then we have arrhythmia and sudden cardiac death. And of course, infective endocarditis, because you have a valve that is predisposed to pathologies because it is sick, like, it's malformed. It has pathology. So it's high risk for infective endocarditis. Cool. So that's aortic stenosis. So let's go to aortic regurgitation. Aortic regurgitation, as you said, regurgitation is a situation where the valve is not closing. So what you have is backflow of blood into the chamber that it is going to come from. And normally, this is going to manifest during diastole, because during diastole is a phase where you'd need to have your aortic valve closing so that you can have filling of the left ventricle, so that you can prepare to pump blood out again. So in that case, so this is just shown up here, is where you have, just see. So this is where you have the aortic valve, and you may have various causes of regurgitation. They may be primary, so which are cuspal defects, or they may be defects in the attachments. Remember, we talked about factors responsible for the integrity of valves, and the cuspal attachments are a critical part of that. So you may have things like aortic root dilation in conditions such as Marfan, or among others, where the root of the aorta balloons, so it also pulls apart this valve such that it doesn't oppose or close completely during diastole. So what happens? Blood flows back. So as it's supposed to, it flows back into the left ventricle. So you'll have a lot of blood building up within the left ventricle. And what does that cause? It causes an overload, and also causes an increase in systolic blood pressure, because you have a lot of blood. So you have blood that's coming from here, blood that's also coming, that's flowing back, and so it leads to a difference or an increase in what is known as a pulse pressure. If you remember from physiology, pulse pressure is, that difference between the systolic and diastolic blood pressure. And when you have an increased pulse pressure, you have a circulation which is known as a hyperdynamic circulation, and aortic regurgitation is one of those causes of hyperdynamic circulation. And again, because of the overload, this compared to the aortic stenosis, this is not going to be a pressure overload, it's going to be a volume overload. So it leads to a different type of hypertrophy, which is known as eccentric hypertrophy. For pressure overload, you usually have concentric hypertrophy. Here you'll have eccentric hypertrophy, where you have, the dilation. So as you said, the causes, again, rheumatic heart disease is a culprit in almost all valvular heart diseases, infective endocarditis, congenital, degenerative, or it may be also perforation of the valve. That's primary. Primary refers to when it's the cusp that is the problem. Then functional is when it's the attachments of the cusp that are problematic. So the factors responsible for integrity are also where the valves attach. So you may have conditions, as I mentioned, aortic root dilation, which may be caused by different things, such as degeneration, syphilis aortitis, which is may lead to an aneurysm, mycotic aneurysms, ankylosing spondylitis, rheumatoid arthritis, Marfan syndrome, among others, may be responsible for aortic root dilation, which is a functional cause of regurgitation. And then auscultation, again, aortic area, because you're trying to, and then Ab's point, which we mentioned, you can hear all heart sounds clearly. And then the murmur, you forget everything, because there are so many layers to describing a murmur. At least be able to know that it's a diastolic or a systolic murmur. The rest you can cram. But then at least this one you can be able to understand. And it's easier when you understand why it's a diastolic or a systolic murmur. And because when you try to cram all of them, it becomes a bit confusing. So it has what is known as a decrescendo, a diastolic murmur. And this murmur is an early diastolic murmur. And also has what is known as an Austin Flint murmur. Yeah, so it's an so you ever hear that Austin Flint murmur, that's aortic regurgitation. And importantly, it leads to a hyperdynamic circulation, as we mentioned, due to the widened pulse pressure. And so in terms of its clinical presentation, which is high yield, you have the features of hyperdynamic circulation, which are shown by this man who is known as, the aortic man. So usually have various signs. There are so many, but important ones are, this one for the carotid, which is known as the carotid neck sign. You have Muller's sign, which is like a uvula that is dancing, and then you have water hammer pulse in the arms, which is a collapsing pulse. Others, lighthouse, Demoiselle. There's so many. You may have pistol shot femoral strobes. There's so many different signs. Yeah, but all these signs, there are so many different ones, all associated with the hyperdynamic circulation, which manifests in aortic regurgitation. Nice. So complications, again, we said, because of volume overload, you will have eccentric hypertrophy, which will lead to left ventricular heart failure, which could also again lead to arrhythmia and sudden cardiac death. And then because the valve is has a pathology, it's also at risk of infective endocarditis. So this is just a quick summary of what these valves look like. The different causes. You can just ignore whatever is down here. Maybe you can read if you want, but just trying to show You can have functional, or it's, this aortic root dilation, but then on top of that, you can have defects in the cusps themselves. It could be perforated, it could be prolapsed, it could be calcified, it could be retracting or not closing properly. So you can have different. So there's layers to this. Again, it's just, since it's just a basic overview, we'll just move on quickly to the next one. So that's it for the aortic valve. We've looked at stenosis, the causes, the presentation, and and everything about it, as well as aortic regurgitation. So now let's look at the mitral valve. Yes, so I should have erased all this, but well, we'll just use it again because it's going to save time. So we look at mitral valve. The mitral valve, we said, is this bicuspid valve that separates the left atrium from the left ventricle. So stenosis, we said, is narrowing. So when you have a situation where this valve here is narrowed, this mitral valve here, what that means is that you have failure of blood to move from the atrium down into the ventricle. So what that means is that you will have a lot of pressure building up in the atrium as it's trying to push against a mitral valve that is not opening. And this means the issue is ventricular filling. And that means the mama you're going to have is a diastolic mama, because it's manifesting, during as you're trying to fill the ventricles. So it's going to be a diastolic mama. So at least remember it's going to be a diastolic mama. And how it's going to present, you will have blood pooling in the atrium. So it's going to pull, and then so that means because it's just going to stay there and it's going to be stagnant, you have high risk of forming clots. So you have a big clot that's going to form, and it may and then embolize, and going to be big problems. And then you will have a hypertrophy of the atrium in this case, hypertrophy of the atrium, and so you have a ballooned left atrium. And so once you have ballooning of the left atrium, the relations of the left atrium now start being affected. So usually you have posterior relations of the left atrium, such as the esophagus and the recurrent laryngeal nerve on the left. So you will have presentations such as dysphagia, also speech, whatever sound dysphonia due to, hoarseness of the voice due to compression of the recurrent laryngeal nerve. And yeah, so and then because blood isn't getting to the left ventricle, in this case, the left ventricle is not going to be hypertrophied. It's actually going to be small because it's not getting enough blood to pump. Whatever is going to be enlarged in mitral stenosis is the left atrium. Good. So again, the causes, rheumatic heart disease is suspect and criminal. Again, in this it's implicated in all these valvular heart diseases. And for auscultation, you auscultate at the mitral area, which is at the apex, at the left fifth intercostal space. And the mama, as you said, just remember it's a diastolic mama. Then the characteristics, it's said to be a delayed diastolic mama with a decrescendo, and its characteristics, it has an opening snap and a diastolic rumble. So the opening snap is because build up of pressure as it's trying to push blood from the atrium, and then it finally opens, and then you'll have probably the rumble is as blood is entering. Yeah. So the presentation, as we said, hoarseness of voice, dysphagia due to the relations of the ballooned or enlarged left atrium. And then you'll have widening of the carina because it's going to push up. The carina is the bifurcation of the trachea. So it's going to widen it. And that you may see that on X-ray or on imaging. And atrial fibrillation, which is an important complication of of mitral stenosis. And then for hemodynamic complications, because blood is not passing down into the ventricle, it's going to congest and go back into the lungs. So you'll have pulmonary congestion, and it's also going to go back all the way into the venous circulation. You'll have what is known as mitral phases, where the face looks puffy and red, and the cheeks look swollen, and like the face looks a bit so in mitral stenosis, and that is what is known as mitral phases. And again, you will have, remember, because it's flowing back into the right, so you're putting a lot of pressure into the right heart, the right side of the heart. You will have right ventricular hypertrophy. Remember, not left. The left actually becomes small, but this is like chronic eventually. And then you may also have thrombi because of the clots that may break off from the collection of stagnant blood, because you have stasis. And then again, infective endocarditis and low cardiac output. So this is what, on gross pathology, this is what stenosis looks like. And in rheumatic heart disease, it has what is known as fish mouth. This is an attempt to make it look like a fish so that it's memorable. It actually does look like a fish. Yeah, I don't know that you can see it, but I can. Yeah. And then you have fusion of the commissures, as you can see, pointed by the arrows. And then, so this is known as fish mouth or buttonhole. 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 Okay, I've just been a question. Dysphagia is because I said posterior relations of the atrium. One of them is the esophagus. So yeah, I think we used to be asked that in ANAT. Relations, posterior relations, so they're usually a number. So the posterior superior relations of the left atrium, they're important, and this is why they're important, because in an enlarged left atrium, it's going to compress the esophagus, the recurrent laryngeal, and it's also going to push up the bifurcation of the trachea and widen the carina up there, just above it. Yeah. So this is also known as buttonhole stenosis, because if you look at a shirt, this looks like the hole of a button, the one you usually put in as you're wearing a shirt. This stenosis, it kind of does. So that's why it's also known as buttonhole stenosis. And yeah, nice. And then let's look at mitral regurgitation. So if you look at stenosis, regurgitation, again, as you mentioned, regurgitation is when the valve is not closing properly. So you'll have so now with the mitral valve, the issue of it not closing is going to be a problem during systole. Why is it during systole? It's because it's during systole, as you want to pump blood from the left ventricle through the aorta, you don't want blood going back into the left atrium. So you want the mitral valve to be shut. But then that doesn't happen. So it keeps, so it pushes blood into the left atrium. And so the mama you're going to have here is going to be a systolic mama. And so you'll have, again, because of blood, so the blood is going to be going and coming back again into the left ventricle. You'll have overload of volume overload of the left ventricle, and you'll also have hypertrophy because of that. So yeah, so that one is pretty straightforward. But then the causes are important of mitral regurgitation. You can have primary causes, where we say primary is when it's the valve itself which is the problem, it's the leaflet. So you have anatomical issues with that. So it could be scarring, again, due to rheumatic heart disease, infective endocarditis, and then also something known as mitral valve prolapse. So I'll quickly just show what mitral valve prolapse is. Remember, we showed the various layers of the heart valve and what a normal heart valve looks like. And you showed particularly the fibrosa is what is affected, if I'm not wrong. And so, instead of having that connective tissue, collagen, that gives you tensile strength, you have its replacement with what is known as myxomatous material. Like this is abnormal, disorganized tissue. And you have what is known as myxomatous degeneration of the valve, and it leads to hooding. Hooding is, as shown by this arrow in the first image A. Hooding, so it protrudes into so it prolapses upwards. So when you say mitral valve, it doesn't prolapse into the ventricle, it prolapses up into the atrium. So you have hooding of them, and all these ones are just showing the same thing. So that is what mitral valve prolapse is. It's associated with conditions, those connective tissue disorders, such as Marfan's, among others. And then drugs. Then functional mitral regurgitation. As you said, the integrity of the valves is dependent on the valves themselves as well as their attachments. And for the atrioventricular valves, the attachments are many. They attach to the walls, to the ventricles, and the annulus, which is the ring which supports the valves. And they are also supported by subvalvular apparatus, which are the papillary muscles and the chorda tendineae. So you could have rupture of papillary muscles in conditions such as myocardial infarction, which I think will be covered in a CME, I think 2 or 3 weeks from now. And then you can have papillary muscle dysfunction, could be dyskinesia of these papillary muscles. They're not working in a coordinated fashion, and that can also cause functional mitral regurgitation, or you can have rupture of the chordae tendineae. Those strings may snap. And once they snap, you'll have the anomaly of that. And then an important one, now when it comes to the left ventricular enlargement. So when you have dilated cardiomyopathy, as you mentioned, the ventricle and the annulus are important supporting structures. So when you have dilated cardiomyopathy, it subsequently usually leads to mitral regurgitation because it's, as you said, the hinges, once the hinges of a gate are pulled apart, you find that the gate is also now not closing properly. So dilated cardiomyopathy also leads to mitral regurgitation, and then you can have calcification of the mitral ring, etc., etc. And then its auscultation is at the apex, because it's the mitral area. The murmur, remember you said it's a systolic murmur, but it's specifically a holosystolic murmur that radiates to the axilla. So it's a holosystolic murmur that's blowing and radiates to the axilla. And then mitral valve prolapse is a bit unique. The murmur is not very similar to the others. It's a late systolic murmur associated with a mid systolic click. But then just remember it's a systolic murmur when it comes to mitral regurgitation. The presentation complications, they said atrial enlargement, because blood is being pushed back into the atrium, and then the ventricle will also be enlarged because of volume overload, and complications, congestive cardiac failure, infective endocarditis, atrial fibrillation, and that kind of makes sense if you put it all together. So for tricuspid, it's exactly the same. So it's exactly the same as the mitral, just that now it is the right side. It's the right side of the heart. So the only thing that is maybe important here, maybe to mention, is that the auscultation area is the tricuspid area, and that now, when it comes to stenosis of the tricuspid, you will have congestion. What will be congested now is going to be very predominantly the systemic circulation and the liver venous congestion. Because if blood is unable to flow into the ventricle from the atrium, it pushes back. So imagine down through the inferior vena cava, up through the IVC. So you'll have systemic congestion, edema, ascites, engorged neck veins, and elevated JVP, hepatomegaly. That's what's known as a nutmeg liver, etc. So this one, I won't focus too much on it since it's not also that common. And then there's one unique cause of tricuspid valve disorders, which is carcinoid. In carcinoid syndrome, where you have a tumor, probably a tumor which is secreting a lot of serotonin, it usually leads to malformation of the tricuspid valve. And you can see on histology, the tissue is also a bit disorganized. Good. So you've noticed that we've talked about rheumatic fever and rheumatic heart disease a lot, because that is, in our setting, it's the most common and it's also highly examinable. So I'll just quickly rush through it. Again, excuse the bad handwriting. I've made them better. The slides look nicer, but they still look legible, I hope. So rheumatic fever is defined as a delayed inflammatory sequelae sequelae is a consequence or something that comes after, that affects the heart, joints, skin, and CNS 2 to 4 weeks after an untreated infection with group A streptococcus. So it's an inflammatory condition which comes as a consequence of group A streptococcal infection, and it's delayed. It comes like 2 to 4 weeks, and it's usually, this infection is most commonly tonsillitis or pharyngitis, and when it's not treated, it leads to this complication of rheumatic fever. And what happens is that it's a mechanism known as molecular immunological mimicry or molecular mimicry, whereby the body's host defense, that is whatever it prepares, both in terms of humoral immunity, which is antibodies, as well as cell-mediated, they cross react with the body's tissues. So you'll have damage in the heart, damage in the brain, every joint. So it affects multiple areas. And the presentation is, you usually have constitutional symptoms such as fever, malaise, and fatigue. But then you have major manifestations affecting the skin, or you have erythema marginatum, subcutaneous nodules, migratory polyarthritis. Heart is affected, which we'll focus on in a few minutes. And then the central nervous system is also affected, where you have Sydenham's chorea. So I'll just come here. So this is what is known as Jones criteria. This is, I think, the modified one. So for diagnosis of rheumatic fever, so its major criteria is this mnemonic Jones. So it's very convenient. So J is for joint involvement, and this joint involvement has characteristics. So it's usually migratory, and it's polyarthritis that affects the major joints. So it doesn't affect the small joints, it affects the big joints. And it resolves by itself. And I think it also responds to aspirin. Yeah, if I'm not wrong. And then O, the O looks like a heart, so stands for rheumatic heart carditis. And then N is for nodules, the subcutaneous nodules that we showed. Then erythema marginatum, then Sydenham's chorea when it affects the basal ganglia. And then you have the minor criteria, which can be used the mnemonic cafe PAL. So you see increased CRP, arthralgia, joint pain, fever, elevated ESR, prolonged PR interval, anamnesis of rheumatism, leukocytosis. So normally, not all of them are mentioned, but these are the minor criteria. And generally, to reach a diagnosis, I need a positive swab or elevated titers of anti-streptolysin O, which is this antibody which is produced against the bacteria, which is also cross-reactive, plus two major criteria, this one's here from Jones, or one major criteria and two minor criteria. So that's Jones criteria for rheumatic heart disease. And to emphasize just the manifestations, these are the major manifestations. This is just a plot of time showing how they manifest and whether they so most of them resolve after some time, but then there are some that persist for longer, like the chorea. Yes, and you already described the characteristics of this polyarthritis of rheumatic fever. So rheumatic heart disease, this one is highly, I think it was also tested during our year, because I think they tested both rheumatic heart disease and post-streptococcal glomerulonephritis. So it's an important condition. And how it presents as two clinical entities, an acute pancreatitis and chronic valvular changes. So the acute pancreatitis, pan means all layers. So it's going to affect the pericardium, the myocardium, the endocardium. And you have deposition of granulomatous lesions, which are known as ash of bodies. And these are usually pathognomic for rheumatic fever in all three layers. So you have pericarditis, what is known as a bread and butter pericarditis, and then you have myocarditis, and then endocarditis. So you'll have lesions which are known as verrucae, which are usually along the lines of closure of the valves, as well as what are known as McCallum plaques, which are usually subendocardial lesions caused by jets that are formed from the blood that is under too much pressure. That is the first entity, acute pancreatitis, which consists of all those things you just mentioned. And then the second one is chronic valvular changes, which is usually, chronic and problematic and lifelong. So you have those deformities you showed, fish mouth deformity, or you have connective tissue deposition, organization of fibrous tissue, and thickening of the valves. And so it becomes a valve that is very stiff. And so it leads to stenosis, regurgitation, or both. And typically, the mitral valve is usually affected most of the time, 99% of the cases, and in 65% of the cases, it's going to be affected alone. In other cases, it may be affected together with other valves. And in various age groups, the type of lesions you get differ in rheumatic heart disease. So between the ages of 5 to 10, you mostly get predominantly regurgitant lesions. Between 10 to 15, you get mixed, where you have mitral and you have regurgitation, then mitral stenosis and aortic, and then past the age of 15, you mostly get stenotic lesions. But then the most commonly affected age group is this 10 to 15 years of age. They're the most affected. Again, this is just the pathology where you're trying to show this granulomatous lesions known as ash of bodies, which consist of giant cells known as Anitskau cells, which are giant cells. And then you have verrucae along the lines of closure. And then the chronic manifestation is usually this. So stenosis, then thickening of the valves, and commissural fusion, as you can see. So complications, it presents with mitral stenosis, left atrial dilation, congestive changes of the lungs, just the same things we mentioned about mitral stenosis. And so congestive heart failure, infective endocarditis. So how is this managed or prevented? So this just took a schema from ComHealth. Again, excuse this handwriting here. So you have levels. In ComHealth, you talk about different levels of prevention: primordial, primary, secondary, tertiary. So in primordial, this is where you're dealing with risk factors. You're trying to ensure that people don't even get exposed in the first place. So you're dealing with risk factors such as poverty, inequality, living in crowded living conditions, and such things. So you prevent people from being exposed in the first place. And then for primary prevention, now this is someone who's been exposed, they've gotten the infection, but then you don't want them to get rheumatic heart disease. So what do? You should diagnose and treat rheumatic, group A streptococcal pharyngitis early. So you treat using penicillin. And then secondary prevention is now, this is someone who's developed rheumatic heart disease. So what do? You treat them and you ensure that they don't get it again by giving prophylaxis. Sometimes lifelong, others it's they usually guidelines. Some, I don't know, to the age of 21, others to the age of 40. Those ones you can always just look at. And then tertiary intervention is now when it complicates. This person probably has serious conditions, and so they need either surgical intervention or to be on anticoagulation to avoid getting clots. So that is how you manage it. So I'll quickly fly through infective endocarditis, which is among the last parts. So infective endocarditis means anatomical. Infection is anatomical presence of a microbe. Endocarditis is in the endocardium causing inflammation. And it forms vegetations, which are combinations of fibrin, microorganisms, and inflammatory cells within these valves. And it's mostly bacterial. And risk factors can be categorized into two, as you can see in this schema here. You have valve problems as well as events that would lead to bacteremia. So the valve problems can be native valve. Native valve is your own original valve, which could be affected by some pathologies, as we said, prolapse, rheumatic heart disease, etc. So you have an abnormal native valve, or you could have a prosthetic valve, infective endocarditis, or a device-related infective endocarditis, such as pacemakers or defibrillators in situ, which predispose you to that. And then you have events that lead to bacteremia, such as intravenous drug use, catheters for hemodialysis, dental procedures, which cause bacteria to get into the blood, recurrent infections, immunosuppression, etc. And all those will lead to, bacteria getting to the valve, and they'll start damaging it, and then they'll proliferate, and they'll, have an immune reaction, and they'll continue damaging the valve. Yeah. And and then eventually you'll even have septic vegetations to different parts of the body. And so complications of infective endocarditis include heart failure. That's the most common. And then you may have abscesses within that area where the bacteria are developing, and then arrhythmias, etc. You can have those, as I said, you can have break off of those emboli, and they may cause strokes, ischemia of limbs, etc. And they may also spread to the brain, meningitis, etc., and may damage kidneys, joints, etc. So you have this common thing that's usually asked there. Peripheral stigmata of infective endocarditis. You usually have these ones. You have splinter hemorrhages, which are these ones seen under the nails. And then you have rod spots seen in the retina, Osler's nodes, which are painful. Remember, Osler's nodes are painful, seen under, the skin, particularly in the fingers. Clubbing, clubbing, usually a mnemonic in the, so clubbing is a mnemonic for causes of clubbing, and that I in that mnemonic usually stands for infective endocarditis. But you have these fingers that look like drumsticks. And then you have Janeway lesions, where you have this non-tender. Janeway lesions are non-tender, Osler's nodes are tender in the palms and soles. And you can have different mechanisms. So immunological mechanisms are such as the rod spots and Osler's nodes. Those are immunological, and embolic phenomena are like Janeway lesions and splinter hemorrhages. Those are embolic phenomena. And the criteria for infective diagnosing in endocarditis is also highly examinable. It's known as the modified Duke's criteria. So the mnemonic you can use for this, B timer, BE is the major criteria, where you can have a positive blood culture more than 2 times 12 hours apart, as well as echocardiographic evidence of endocardial involvement. So echo is an ultrasound of the heart or a new mama developing. And then the minor criteria is what you can use as timer. So you have fever, T is for temperature, fever, then you have immunological phenomena, such as the ones you mentioned, Osler's nodes and rod spots, microbiological evidence, embolic phenomena, as you mentioned, as well as presence of risk factors. And the diagnosis can be either definitive or probable or possible. Definitive is when you have 2 major criteria, or 1 major and 3 minor, or 5 minor criteria. And then the possible diagnosis is when you have something that's not too sure, whether you have 1 major and 1 minor, 3 minor, like it doesn't meet that threshold for definitive diagnosis. So this is what it looks like on on gross pathology. You can see this how this valve has been damaged. We saw what a healthy valve looks like. This is the complete opposite, caused by various bacteria, which we're going to look at. So you have 2 categories of infective endocarditis. It can be categorized as acute or subacute. Acute is when the duration is less than 6 weeks. Subacute is when it's more than 6 weeks. And the most commonly offending organisms in acute are Staph aureus and the beta streptococcus. So, beta hemolytic. So this is like pyogenes. So in acute, the virulence of the organisms is really high. They are very virulent, and they cause a lot of damage and devastating to the valves. And they even affect normal valves, not valves that are originally damaged. They find normal valves and they damage them. and they lead to invasive, suppurative, and destructive lesions, and leads to an acute systemic infection, and this one can lead to death very fast. This is severe. Acute endocarditis is severe. Subacute, on the other hand, is most common organisms is viridans streptococcus, which is less virulent, causes less damage, and yeah, so most of the presentations will be also more subacute and chronic, clubbing, petechiae, signs of congestion, etc. So those are the differences between acute and subacute infective endocarditis. And based on etiology, you said you could have native valve, you could have prosthetic valve, or you could have, when you have nosocomial, such as ones you have devices in situ. So you could have prosthetic valve is divided into two, early and late, with different organisms. Early is caused by stuff, epidermidis and aureus, things that you typically find in the skin, like normal flora on the skin. And then late is caused by strep, as well as this group of organisms known as HASEC. So for some reason, this is usually an MCQ question, but yeah. And then infective endocarditis in drug users. This one, the thing you need to remember about it is that it also affects the right side. So there's this mnemonic, this that says, don't try drugs for the sake of your tricuspid, because in drug users, the right side of the heart is affected. And in this case, you have Staph aureus, Pseudomonas, fungi, and then in people who have HIV, you also have organisms such as Bartonella, Salmonella, and Listeria coming in. And then in nosocomial endocarditis, people who have these devices in situ, catheters, etc., or they've had some interventional cardiology procedure, Staph is an offending organism, as well as Enterococcus. So that is it for infective endocarditis. And then now to the last part, which is non-infective endocarditis. You have two types. Okay, different. Yeah, so you have what is known as NBTE, which is non-bacterial thrombotic endocarditis, which is commonly seen in marasmus, dilapidated patients who are very malnourished. In cancer, what is Trousseau syndrome, which is a paraneoplastic condition, which you have a hypercoagulable state. It also has its valvular manifestations. And then in SLE, systemic lupus erythematosus, you have a type of endocarditis known as Liebman-Sachs endocarditis. And this is what they usually look like. So you already looked at rheumatic heart disease. In the acute, where you have the verrucae, these very small vegetations along the lines of closure of the valve. Infective endocarditis, we already showed how you have these large friable vegetations. And then now in NBTE, you have this non-bacterial thrombotic endocarditis, which occurs in marasmus, malnutrition, Trousseau's, some cancers. You have bland, so these ones are not, they don't have pus, they don't look like it's a bacterial infection going on. But then remember, they are also friable. Friable means it can break off and embolize and spread. And then these ones that are Liebman-Sachs endocarditis associated with lupus, you have these ones that are small and found on either side of the valve leaflets. So at the top and at the bottom, that's usually characteristic for Liebman-Sachs endocarditis. So in patients with lupus, and if you hear a murmur, it could be due to Liebman-Sachs endocarditis. So as we end, we'll talk about prosthetic valves really quickly. There are two categories which we won't go into. So you have mechanical and biologic. So you have so many different types, but biologic are basically made from, other animals like pigs. So you'll have like xenograft from pigs, whatever. Yeah, so they are fashioned and then implanted, and then you have mechanical ones, which are, like metal ones. And so those differences are significant and are also asked sometimes. So for prosthetic valves, which are biologic, bioprosthetic valves, the advantage is that you don't need coagulation for life. There's lower risk of bleeding since you're not on anticoagulation. And yeah, and you can use them in patients with comorbidities such as cancer, renal failure, etc. But then the issue is that because they are biologic, they get attacked by the immune system really fast. So you need to keep reoperating and replacing the valve after a shorter duration of time. Whereas mechanical, yes, they are durable, and so they are good for young patients since they are durable and will last for long. The issue with them is that there is a higher risk of thrombosis, since this is very artificial metal, so it's going to form clots, and because it's like a metal, so it also causes a lot of hemolysis. It chops up those red blood cells, and you'll have hemolysis and jaundice in patients with mechanical valves. So again, this is just a repetition of that summary. So complications of cardiac valve prosthesis. So you may have thrombosis, anticoagulant related hemorrhage, because these patients are on anticoagulants for long. You may have endocarditis. Then you may have wear and tear of the valves. So the valve just collapses, it prolapses, or it stops working. In other cases, you may have a valve that is not even fitting, so it's too small. So you have what is known as paravalvular leak. So it's leaking on the side. So instead of blood passing through the valve, it's passing on the sides of the valve, like so. And again, hemolysis, as you mentioned, or exuberant healing, where you have too much connective tissue covering the valve. So that is it. That is the end for this presentation. It was quite long since we was covering different areas of valvular heart diseases, but I hope it was a nice summary. And yeah, so that's it. Yes, thank you for your time. Over to you, Lena.
Thank you very much, Felix. Yes, it was a very good presentation. I believe we've all learned a lot. And yeah, it was a very nice one. So now we have the session on the question session. So I'd ask you guys to log in to Kahoot. Let me type out, I'll type out the name on the chat, the link. So it's kahoot.it. Brian is saying wonderful presentation. Yes, it was very good. Okay. Yes, that is the yeah. Excuse Are we on Kahoot, guys?
Lena, you could share your screen. Oh.
Okay. Can you see my screen?
Yes.
Okay. Okay, so we're about to start. I hope we're all together. So the game pin is 8897245. I hope you can see the screen. There's also a QR code, you can scan it. A few more seconds for the ones that are still joining, so we can start off. Okay, I'm about to start. So if there's anyone joining, please, 2 seconds. Save on time. Welcome on. Okay, so we'll start. Okay. So the first question is up. Okay. 6 of us got it right. The answer is mitral stenosis. Yes. Yeah. Okay. Next. So the scoreboard, we have AJ leading, followed by Kim, and then Ian. Yes. Okay, let's continue. The next question is up. Okay, so the answer is mitral agitation. 7 of us got it right. And let's see the scoreboard. So we still have AJ leading, good, followed by Kim, and then NM. Yes, I think the faster you type in your answer, the higher your scores are. So let's try put it in a bit faster. Okay, next. Okay, so the answer is mitral stenosis, and most of us got it right. So all the following associated with cardiac left axis division except it then says mitral stenosis. So we have, let's see. Okay, now we have Kim leading, followed by AJ, and then good job, Kim. Vic has a streak with 3 correct answers in a row. Very nice. Very good, very good. Okay, next. Okay, so here, all the following are causes of functional mitral regurgitation except the answer is the blue in blue, post-inflammatory valve scarring due to rheumatic heart disease. A number of us we didn't really have this, but the answer is post-inflammatory valve scarring due to rheumatic heart disease. It's not associated with functional mitral regurgitation. Okay, next on the scoreboard. We have NM followed by CV and then Vic, and CV has a streak with 4 correct answers in a row. Good job. Okay, next. Okay, so the answer is aortic regurgitation. Atenu is a 53-year-old woman with rheumatoid arthritis and has collapsing pulse of her carotids. She has aortic regurgitation. Okay, so we have NM still leading, followed by Vic, and then Kim, and Vic has the highest answer streak. That's good. So next question. Okay, so Kamau is most likely to have aortic stenosis. Yes, that's the answer. The scoreboard, we have NM still leading, that's good, followed by Vic, and then Kim, and Vic still has the highest answer streak. Okay. Okay, the answer is in red. It typically affects the metacarpopharyngeal joints. That is not true. All the rest are true. About arthritis due to rheumatic fever. Okay, so the scoreboard. Um, Still have NM still leading, followed by Kim, who also has a good streak with a 3 in a row right answer, followed by CV. Yes. Okay, so the answer is patent ductus arteriosus. It's the heart condition that presents with a holosystolic machine like mama. Yes. So for the scoreboard, NM is still leading. Very good job. Followed by Vic and then CV. Yes, next. Okay, so the answer is Staphylococcus epidermidis. It's the organism associated with early prosthetic valve endocarditis. Yes. For our scoreboard, we still have NM leading, very good. And he has the highest answer streak of 9, followed by CV and then Vic. Next, and to the last question. So we have the answer as Liebman-Sachs endocarditis, sorry, endocarditis associated with lupus. So it's the vegetative endocarditis that's observed on both sides of the valve leaflet. So to see our winner, position 3, we sorry, we have Vic at position 3. At position 2, we have CV, and at position 1, for our winner, we have NM. Yay! Clap, clap. Yes. So that's all for the Kahoot game. I hope you all enjoyed it. And NM, if you have a victory speech, feel free to unmute and tell us. Yeah. Let me stop sharing my screen. Okay. NM, are you around? Oh, you're here. Would you like to say something?
Oh, hi.
Hi.
So, Lynn, like the session today, it was very informative, maybe revise some things I learned in fourth year. Yeah. So I'd like to moderators today for the session today.
Okay. And thank you for participating as well, and congratulations. I hope you all had a good time. Jane, I'm sorry I didn't see your message earlier, but I hope you managed to see the questions. Okay, so I hope you all had a good time and you learned a lot. And now I think I'll invite Hadia for an announcement, for our big announcement. Yes, so Hadia, the floor is yours.
Hi, everybody. Okay, so I'm excited to be here today. Most of that excitement, like 80%, is like absolute terror of, new people and all that. So my name is Hadia. I am a second year at University of Nairobi, MBCHB. I don't know if there's other courses here. So I've been working together with XYZZ to produce an embryology podcast that is currently on SoundCloud, and we hope to also get it up on Spotify. A round of applause. So, okay, this is very scary. I can't hear anyone. So, podcasts are the new in thing, at least since COVID. It's very helpful when you're trying to maybe get some work done and you just want to have something in the background, maybe learn something new. It so yeah, I don't know, maybe I could present my screen and show you our podcast currently up right now. Let me just open it. Oh my God. What? Wait. Can you guys hear me?
Yes, Haida, you can hear you very well. You're doing great.
Oh,
We can hear you.
okay. Okay, so let me my screen. Okay, so this is the podcast right now on SoundCloud. So we started with just like basic embryology. There's gametogenesis, the reproductive cycles, all that you can see. But hopefully we're gonna expand into other areas, other units that we cover, pharmacology, IMED, and I'm hoping other people can also join us to expand. Yeah. So that's it. Please give it a listen. Thank
Okay.
you.
Thank you, Hadia. That's a very nice venture. We'll make sure to check it out. It was very good. It's a very good idea. Yeah, so I guess that's all for today. I'd like to thank Felix for the very, very good presentation. I believe we've all learned a lot, even with he was complaining about the handwriting, but it was the presentation was still very, very good. Yeah, so thank you all for participating, for joining, and for being active participants and team members. Yeah, so have a lovely weekend and have a lovely day. Does anyone have any questions before we close or anything to say? Let me look at the chat, see if there's anything. Joy says awesome session. Thanks. Thank you for joining. It was great. Yeah, so I think we'll leave it at that. And thank you all for the kind comments. So have a lovely day. I believe you can log out.